let's pray to St. Michael, in the name of the Father, and the Son, and the Holy Spirit. Amen. St. Michael, the archangel, defend us now. Be our protection against the wickedness and snares of hell. May God relieve you whom humbly pray, and the hour and prince of heavenly hosts, by the power of God, cast into hell Satan and all the evil spirits who prowl about the world, seeking the ruin of souls. Amen. Sacred Heart of Jesus, pray for us. Immaculate Heart of Mary, pray for us. Heart of Joy, pray for us. Thank you. So that's the last thing you're going to hear about Catholicism, because to be a Catholic physician today is to be completely canceled, and you're not allowed to say anything, and you're going to get fired. And that's the reality. It's not an exaggeration. So I'm a plastic surgeon who is specialized in microsurgery, and that is connecting small blood vessels and nerves with an operating microscope with suture material finer than your hair, using needles that are 75 microns big. So what do you need that for? Well, if someone were to amputate a hand or a finger, you can reattach that. And then we can also take tissue from one side of the body and transfer it somewhere else. These techniques I learned at UCSF here in San Francisco and at the Bunkie Clinic. So in those days, we would transplant a toe to the thumb to make the hand work. We would transplant part of the fibula to make a jaw. We could take the tummy tissue and transplant it to the chest for women with breast cancer. That's what we did. Today, those same centers where I trained, their claim to fame now is transgender surgery. So I've done a lot of these procedures, but I've only taken care of transgender patients who had complications. So I've been a long-standing board member of the Catholic Medical Association. And again, we're one of the few organizations that are actually standing up against transgender medicine. I would not be welcome to give this lecture at the medical school that I have clinical appointments to, but more important, I'm not welcome to give this lecture at the Catholic healthcare system where I work. So that tells you something. All right. So this could possibly be one of the greatest scandals in medical history. And you say, wow, you're really overstating it. But those aren't my words. They belong to Christopher Gilberg, who's a neuropsychologist in Sweden. And he's the one that coined this as being perhaps the greatest scandal. And you say, well, wait a minute. You know for sure that at the University of Washington, they published a paper just the other year, about 2 years ago, and it went viral. It was all over Channel 5 News in Seattle, and then the Associated Press carried it. And they showed that if you block children's puberty and give them cross-sex hormones, you're going to improve their mental health. You're going to have a 73% lower odds of suicidality. That's the claim. And in fact, at their gender clinic, they created this.
Study involving puberty medicine researchers found gender-affirming care made a big difference in reducing depression levels for transgender youth.
Who is involved in clinical care of transgender people, transgender youth, and does participate in this research, has very consistently found these similar results. Gender-affirming care is life-saving care. Gender-affirming care really helps somebody live a full and complete life that most of us get to take for granted.
So Erin is a man who's transitioned to be a woman. She's the second author, she's the second author of the paper. Gender-affirming care, as she says, is life-saving care, and anybody involved in the research knows that that's true. Okay? That's the claim. And then, just last year, there was an article in the Wall Street Journal that said gender transition is pushed without evidence. And the president of the Endocrine Society, Dr. Haynes, responded. Now, endocrinologists are specialists who give hormones, right? That's what they are. Now, they are some of the smartest people in medicine. endocrinology is a subsection of internal medicine. These are very, very, very bright people. They have my respect. And so Dr. Hames says, wait a minute, there's 2,000 studies since 1975 that show a clear picture. Gender-affirming care includes the well-being, right? And then this article came out a couple of years ago from the Karolinska Institute in Sweden and Yale University, published in the American Journal of Psychiatry, a very reputable journal. And they looked at mental health studies, retrospective analysis, and they found an average of 8% reduction in mental health. And this article went viral as well. And the Branscombe from the Karolinska Institute said, now we have strong support for providing gender-affirming care. Dr. Pachenkis from Yale, he had an op-ed in the New York Times, and he went on and on. No longer can we say that we lack high-quality evidence of the benefits of providing gender-affirming surgeries to individuals that seek them. This is the Karolinska Institute, this is Yale University, right? Well, guess what? Within that year, Yale University had to file a retraction, the Karolinska had to file a retraction, and the American Journal of Psychiatry had to follow a retraction. So, you don't have to be a statistician to see these are the people that had surgery in the dark, and actually their outcomes were worse. Their outcomes are actually worse. And an investigative reporter looked at the data that was from Washington, or the University of Washington, and he wrote this article. Hormones did improve trans kids' mental health. That's what the data, it didn't improve it, yet they published an article that said it did, that published the opposite, right? So what did the University of Washington, #1 rated school by U.S. News and World Report in primary care, #1. How did they respond? Well, they took down the video. That's all they did. They just took down the video. And when you look at the data, you can see that, and statisticians have looked at it, the control group of patients who were not treated versus those that were aren't standardized. There's a huge amount of attrition in that, and statisticians that looked at that said you can't make any conclusions regarding this data. And so you might not be able to see this. I'll read it to you. This is a leaked internal email from University of Washington Department of Epidemiology. As there is an overwhelming amount of positive coverage of the study's findings, I don't believe there's a need for proactive response beyond continuing to monitor. And the response to the email says, yeah, I read this exceedingly long article, which was the criticism, which claims that the research was flawed, or worse, made up. But given the extremely positive pickup by the mainstream media, and there was, I would agree to just let this be. Wow. I just can't believe that. A university, #1 rated. Oh, we just let this slide. And then the letter to that Dr. Hames had said, 21 clinicians from 9 countries responded. The systematic review doesn't show any evidence of mental health benefit. No systematic review shows that. By contrast, there are significant risks, including lifelong dependency on medication, the anguish of regret, sterility, and Dr. Hames claims that gender transitioning reduces suicide is contradicted by the review in their own journal. And the article written in his own journal says we could not draw any conclusion about death by suicide. No reliable evidence suggests that hormone transition is an effective suicide prevention. I told you, this is one of the most intelligent group of doctors in the world. So how could he not know the published data in his own journal? Is it willful ignorance? Is it, what is it? Is it outright being disingenuous? Is it outright lying? What is it? And the National Board of Health in Sweden said it best. For adolescents and with gender incongruence, the National Board deems the risk of puberty suppression with pubertal blockers and gender-affirming hormones currently outweighs the possible risks. So they banned it except in exceptional cases. And that's why we have all the European countries and some of the Pacific countries putting a halt, including England, Sweden, Finland, France, Denmark, Norway, Australia, New Zealand, Scotland recently. They're completely banning transitioning minors. Italy and Belgium are on their way to look at the same thing. And this came to a head in 2020 with Kyra Bell. Kyra Bell is a young woman who became a whistleblower in the National Health System in England. And she was actually able to sue the National Health System, and very difficult to do in England, but she did it and she won. And the High Court, one of the judges in the High Court wrote in the decision, there is no age-appropriate way to explain to many of these children what losing their fertility or full sexual function may mean to them in later years. And that's the key. Not only are they made infertile, they'll not have any normal sexual function. Right? And so she was the whistleblower that got the Tavistock Clinic in London closed, which was, there's some seats there, I think, which was the largest gender-affirming care clinic in England at the time. And Kara, reflecting on her past, said, what was really going on is I was a girl insecure in my body and experienced parental abandonment. Her mother was a crack addict. She never left the apartment. She then went to live with her father, who had a live-in girlfriend who convinced Kara that all of these problems are probably due to you're probably the opposite sex. So she took her to the clinic, the Tavistock, and they transitioned her. But she says what was really going on, I was suffering from anxiety and depression and struggled with my sexual orientation. As I matured, I recognized that gender dysphoria was a symptom of my overall misery, not its cause. Very insightful, and that's exactly the point. And that's what Gilbert in Sweden is trying to say. These are children who have a lot of psychological wounds, and right away we're lying to them that doing this one thing will change their lives for the better. And so the National Health System, just now, March of 2024, came out with the Hillary Cass review, and so this started, it just came out now, but it started in 2020. And all of the data from the Tavistock clinics were compiled by York University. Independently, they looked at the data, and what Dr. Cass said was what she found was sexless adults, depleted bone density, hampering of cognitive development, and reduced emotional, and what it did is produced emotional problems. And there was no statistically significant difference in gender dysphoria, mental health, body image, and psychological functioning in children and adolescents treated with blockers. So there was no data that any of what happened in the Tavistock Clinic helped anybody. In fact, it probably made things worse. And closer to home, at Washington University in St. Louis, Jamie Reed now made national headline, and she's a whistleblower there. Now, Jamie is very, let's say, accommodating to gender ideology. She says she's a queer woman married to a transgender man, and you can think about what that means in the brain. But anyway, what she says what's happening to children is morally and medically appalling. And that's what's happening in the United States. Morally and medically appalling. So, the only secular point to make is that transitioning, the only reason to transition is to improve gender dysphoria. This angst that you're actually can't identify with your biologic sex. That's the only reason to transition. And as we go through more data, that's the thing to keep in mind. Is it helping somebody improve in their sense of dysphoria? Now, so what's the incidence of transgenderism in the United States? Well, the best data comes from the School of Law, UCLA, and this is the data that the CDC compiles. So we're talking about 300,000 youths and 1.3 million adults. Now again, these are adults that have a lot of psychological baggage. Think about it, 48% have tried to kill themselves. This is why, because they have a lot of psychological issues and depression. 23% actually did try to kill themselves. And that's a basis of psychological pathology. And 26% were addicted to drugs in an attempt to self-medicate themselves. So when we look at the graph from the CDC, what I want to show you is this was the historical incidence of transgender. There was little boys, prepubescent boys. And then now we see this meteoric rise, and this is adolescent girls now. It's a big shift. 69% are now pubescent girls. Why? Because going through puberty as a girl is tough. We raised 4 daughters, I can tell you. They all have angst. And if you were to tell them, well, this is because, you're really not a girl. Of course your periods are awful. And would you like us to stop that? So there's a huge coercion going on in this. And now activists say, well, the rise is because we're accepting now gender ideology. So more and more children are coming out and saying they're gender dysphoric. Well, that's not the case, and I can prove it with data, because in Finland, they noted the same thing. They've always been accepting, but they noticed the same adolescent skyrocketing incidence. And when they looked at their data, they found that natal girls who were born girls, are overrepresented, and that there's severe psychopathology that preceded the gender dysphoria. And a lot of these youths are on the autism spectrum. And so they concluded that you have to consider gender dysphoria in mind in the context of the severe psychopathology and developmental difficulties. And this is what we are completely ignoring in the United States. We're not listening to what people have already said, that already have done. And so the other claim is that gender dysphoria is innate, right? The claim, I was born this way. You have to accept me because I was born this way. And well, that's all disputed and doesn't hold muster when we look at Dr. Milton Diamond's study published, and it was a study of monozygotic twins. So we all understand monozygotic twins are identical twins. Right? So if things are due to genetic, then it happens in both twins. Hair color, 99%. Eye color, height and weight. In monozygotic twins, identical twins, they're the same. But when we look at homosexuality, by the way, or transsexualism, the concordance rate is only 28%, which is very low. So gender dysphoria is not innate. Well, what does it do to it? A whole host of issues. But they're postnatal, right? They're not shared postnatal experiences. And social reinforcement, and I think parental psychopathology, what goes on in families, is key. And these children become wounded somewhere in their early lives, right? And it doesn't have to be sexual abuse, but they undergo some wounding. Something's missing in your life, right? And of course, now we have the social contagion. That's why I think we had that big spike. Because kids are told on TikTok and on YouTube that, well, maybe you're not that sex anyway, and that's what's going on. So social contagion has a lot to do with it. And all of these things play a role in gender dysphoria. Well, do gender dysphoric kids, do they stay that way? There's a seat right here. do trans kids stay that way? And well, look at the assistance studies. And what are those? Well, those are studies, and Dr. Cantor reviewed 11 of them. These are studies that follow kids if you counsel them and leave them alone, basically. What happens to them as they get through adolescence? Well, in this study by Cantor, 60 to 90% of trans kids turn out no longer to be trans by adulthood. And if we look at another study from Toronto, in Dr. Singh's study, 88% had assistance. In other words, they get through puberty, somehow they figure it out, and they don't have this dysphoria anymore. And from Amsterdam, a study by Stinsma had 63%. So the key is, if you left these kids alone and you counsel them, they would actually do fine. All right, most of them, or some of them, would become homosexual or bisexual, but they would have this angst that that they're in the wrong body. Now let's look a little bit at suicide rates. You know, we heard during this meeting that Elon Musk was coerced into giving pubertal blockers to his son because they told him this: it's better to have a live daughter than a dead son. And whistleblowers are saying this is exactly how parents are being coerced in gender identity claims. And it's absolutely a false claim, because we know that 90% of all suicide victims have a diagnosed mental disorder. People who kill themselves have a psychological problem. Normal people don't kill themselves. And gender dysphoria children are no different. And so we have to focus on prevention. And again, from Amsterdam, Dr. Stensma, she showed that 75–90% of prepubertal gender dysphoria children resolve by adulthood if they're neither affirmed or medicated. So that's the data. And now the final nail in the coffin on this issue of suicide comes from Finland. It was published this year. They studied 2,083 gender-confused children, compared them to 16,600 matched controls. Matched for anxiety, matched for depression, matched for autism. And when you match apples to apples, they found that medical gender reassignment does not have an impact on suicide rates. So I hope that's finally going to be laid to rest, but I don't think so. It will be continued to be said as science when it's not. And so I'm sorry to say, this is what we've seen: the death of science, right? People publishing data and giving false conclusions, ignoring data that's published, and that's where we are. And so, you know, all of us ask ourselves, how did we get here? How in the world did we come to this day? Well, I want to take you back to what the treatment was before 2007, and you'll see in a moment why 2007 is an important date for this movement. Now, before 2007, if a child didn't align with his biologic sex, we considered that as a sign of confusion and mental illness. And in fact, gender dysphoria in the old diagnostic manual was called gender identity disorder, right? Then, you know, with the changes in our culture, it was downgraded to a dysphoria. So the child was encouraged to identify with the biologic sex. And say, no, Billy, you really are a boy. And some families chose watchful waiting, and others chose therapy. And 75 to 90% of them would actually get through their biologic sex, accepted their biologic sex through puberty. Again, this was published in the American Psychiatric Association Handbook. It had been published previously. This was known data. So what happened in 2007? Well, the culture accepted this idea that you can be trapped in the wrong body. And at first it started with the adults. And Dr. Bailey from Northwestern University, he wrote, and he had done a lot of study on monozygotic twins, but he wrote then, and it's true today, that the predominant cultural belief that all male and female transsexuals are essentially women trapped in men's bodies has little scientific basis and is inconsistent with clinical observation, and it's true today. Now, at this time, entered the Dutch protocol. Right? This is what happened in the Netherlands. So the Dutch physicians were transitioning people for a long time, and they understood that when they transitioned them in adulthood, they did not resolve their mental health issues. The surgery did not resolve their mental health issues, nor would you expect that it would. If it's a psychological problem, why would you think it was going to cure it? And so by the late 1880s, the 1980s and 1990s, what they ended up thinking was, well, let's take a small group of boys and transition them early. The results might be better, right? And that's what they did. And they produced what was known as this innovative practice model, right? So it was an experiment. They never did any more data. They never created reliable, reproducible research. But what they did create was runaway diffusion. Runaway diffusion. And what is that? That's where the medical community mistakes a small innovative experiment as proven practice. Right? And this rapidly spreads as in a general clinical setting, and it's accepted as clinical practice. And this is really well documented by Procession. Last year wrote this wonderful article, The Myth of Reliable Research in Pediatric Gender Medicine, a critical evaluation of the Dutch studies, and basically said they should have never done it. There was nothing to support it, right? But at the same time now, 2007 again, a physician at the Boston Clinic, Norman Spack, goes to the Netherlands and thinks, wow, this is the best thing I've ever heard of, and comes back to Boston and creates the first gender identity clinic. Again, no data to support any of this. It was an experiment. But he comes back to the United States and he says, that's what we're going to do. And that's the first gender identity clinic in Boston, and then now we're up to 100. And the idea is to affirm a child's desired sex and gender, not their biologic sex like we did before 2007. Have them live socially as the opposite sex. Put them on pubertal suppression at Tanner stage 2, when a child is 10 or 11 years old. Little boys, their scrotum is just starting to increase a little bit. Their testicles are just starting to get larger. Little girls might get a little breast bud. They're just starting. So that's the Tanner stage 2. And these are small kids. They're 10 or 11 years old. Then cross-sex hormones, and then mastectomies when they're 16. This was a protocol that had no evidence anywhere, but we were just kind of making it up. Entered at the same time was WPATH, the World's Professional Association of Transgender Health, formerly known as the Harry Benjamin International Gender Disorder Association. And they changed the name of WPATH, and they started creating these guidelines. Now, these are all gender activists themselves. These are all people that have transitioned in one way or another. So they're activists, but they're going to create these guidelines. And these guidelines took hold and basically coerced all of the medical societies. And they created these guidelines, and then in 22 created the last set of guidelines. And this is the guidelines for pubertal blockers. And I want to just show you. So to give pubertal blockers, the patient, a 10 or 11-year-old, has to demonstrate the emotional and cognitive maturity. Do you have 10-year-olds in your family? And then mental health concerns, if any, have to be cleared up, which didn't happen. And then they have to be informed of the reproductive effects, including the dopey steroid. Now, if you ever had a discussion about sexuality with a 10-year-old, it's not on their radar. They don't care if they never have kids. It's only going to be important to them later when they become mature. So these are these guidelines that are basically nonsensical, that they can't be applied to a 10-year-old or 11-year-old. And in addition, now these guidelines double down that we can only affirm, only affirmation. We can't discuss with a child why they're feeling this dysphoria. That's conversion therapy. If they say they have this dysphoria, they have it. You have to go along with it. And radical patient autonomy. Pubertal blockers, transgender hormone, and then surgery. They're like on a conveyor belt. This is it. We're just on a conveyor belt. And now they removed all the lower age requirements. So you can do this to any child at any age. Now, I know it from a good source that the age requirements were removed by Admiral Rachel Levine. She was really pushing for it. And he was born as Richard Leland Levine, a pediatrician and the current Assistant Secretary of Health for the Department of HHS. So don't look for the Clinton administration, for the Biden administration to come to any aid. They also created a new unique gender identity for young men who want to be castrated and be used. Now they can have their own identity. And they removed the chapter on ethics. Well, I don't, does anybody know the WPATH files? Anybody familiar with that? See what our media is doing? Reporting nothing. Well, this shocked the transgender world. The WPATH files were released on March 4th, 2014. They were leaked to this investigative reporter, Mia Hughes. And it gave us an insight into what really happened in that organization with bulletin boards for discussions. And it revealed medical malpractice on children and vulnerable adults. There are documented discussions about actually transitioning homeless people. How can they take care of themselves as homeless people? They're having a hard time just staying alive. But so this is the radical type of things that WPATH is promoting. And I read all 177 pages and listened to their videos. And in this video, the physician down here, he's a pediatric endocrinologist, and he's bemoaning the fact that he can't really discuss infertility with young 10, 11-year-olds because they haven't even had high school biology. So they have no idea what the reproductive system is, and then they're trying to I think, cover their backs on informed consent, discussing these things with kids that cannot possibly understand. And that's why you have prominent leaders in WPATH like Stephen Levine, who actually authored the Standards of Care 5, and Erica Anderson, himself a transgender female, saying that mental health establishment is failing trans kids, and have left. And recently, there's a WPATH declaration that over 2,000 physicians signed, and the declaration states that WPATH has discredited itself with these standards of care. It can no longer be viewed as a trustworthy source of clinical guidance in the field of gender medicine. And when we look at the membership of WPATH, look what happened in 1 year. In 1 year, they plummeted to 1,590. And if you look, 1,234 are from the United States. This is an American organization, right? And so what I ask you is, how do 1,200 physicians hold sway with 1 million physicians in the United States? Right? There's 100,000 Catholic physicians. Where are you? Why is everybody going along? There's only 1,200 of these guys, and they're making it up. Right? So that's very disheartening. So with these standards in the United States right now, this is the standard of care. You affirm a child's confusion, chemically block them, give them pubertal blockers and lifelong cross-sex hormones, and we know this arrests bone and decreases bone density and prevents adolescent brain maturation. So the adult prefrontal cortex, the executive functioning of your brain in men, does not develop until age 25, right? That's why insurance rates are so high for adolescent boys, right? That's why, because they can't assess risk. That's what the frontal brain does. Now, in order for that brain to mature, you need same-sex hormones. Boys need testosterone for that to happen. It's been known for a long time, and yet we're preventing their brain maturation by giving them estrogen. And this is an article that shows that 1 year of pubertal blockers decreases increases their IQ by 7 points. And of course, they're going to become infertile, and this is not reversible. So this is going to be complicated, and I want to show you why it's complicated. But basically, the hypothalamus gives messages to the pituitary, and then the pituitary goes to the gonads. They produce hormones. They go back via negative feedback mechanism to equilibrate how much hormones there are. So pubertal blockers mimic this hormone and override the pituitary so that there's no more production eventually in the gonads of estrogen or progesterone. So this is the same drug we give to men with prostate cancer to stop production of testosterone. This is the same drug we give to women with breast cancer to stop production of estrogen. This is the same drug we've given to sexual criminals to castrate them medically. And this is the same drug we're giving to 10 and 11-year-olds. So what happens if you give testosterone to a girl? Well, you lower their high-density lipoproteins, the good cholesterol, you increase their triglycerides, you increase homocysteine, which is a protein that causes inflammation in the arteries. You can cause liver failure, polycythemias, overproduction of red cells that makes their blood sluggish, sleep apnea, insulin resistance that leads to diabetes. And we don't know exactly what's going to happen to breast or their endometrial tissue. And then, of course, there's the risks of a double mastectomy. But we're doing all of this as if this is somehow good for these kids. And for natal boys, if you give them estrogen, immediately the risk of thrombosis goes up 5-fold, not 5%, 5-fold. They get cardiovascular disease, weight gain, high triglycerides, high blood pressure, decreased glucose tolerance or diabetes, gallbladder disease, galactinomas or tumors in the pituitary that secrete milk, and then they get breast cancer. Is there any data for the breast cancer? Yes, there is. From Amsterdam, they followed 2260 trans women, men who want to become women, who were on estrogen for 18 years, 46-fold higher risk of breast cancer. Breast cancer is almost unknown in men. But if you take estrogen for a period of time, your chances will go up 46 times. And so this goes against the very nature of physicians who take an oath to do no harm. Because children and adolescents are cognitively and experientially immature. We know that. Anyone who has a kid knows that. And so allowing them to assent, allowing them to make this decision for permanent, life-altering and toxic procedures is a gross violation. It's a gross violation. So there is some good news. The American College of Pediatricians, along with other organizations, these were in your seats there, created a document now that's been signed by 75,000 physicians. And it's a dissenting view saying that the treatment is malpractice. And this is a significant dissenting view of the science and the standards of care. Because in the past, they would say, well, we're just following what WPATH says. WPATH says, this is the standard of care. We're just doing what they say. Now we have a document, 75,000 physicians from 58 countries are saying, no, that is not the standard of care, and it is, in fact, malpractice. And that's why England, Sweden, Finland, France, Denmark, Norway, Australia, New Zealand, Scotland have pulled back on transitioning children and are reevaluating that. Closer to home, these are the states that have put some moratorium, some restriction on transitioning children. And of course, trans activists are saying these are the states that are preventing care to children. And the answer is we're preventing bad care for children. These children need good care. They need psychiatric evaluations. They need to be cared for. They need to be loved. They need a Catholic, authentic care. That's what they really need. They don't need to be given drugs that will change their lives forever. So in conclusion for the medical part, and I'm on schedule, by the way. Gender dysphoria is not innate. Psychological factors are important. The key here is 75 to 90% of these kids would just resolve their gender dysphoria. We just took care of them. We just loved them. We just reaffirmed who they really are. And notice, I'm not using any, I'm giving you secular arguments. Because that's what's important in medical circles. You have to give them secular arguments. If you suppress them, they're going to be infertile, and then they're going to be on toxic cross-sex hormones for the rest of their life. So this is not harmless, as we hear over and over in the media. It's not reversible. And tell me what we're going to do with the 54,000 detransitioners who are on Red. Red is a platform. I'm on it. They won't let me post anything, but I can still read what's going on. 54,000 of kids and adolescents. And their stories are heart-wrenching. And who's taking care of them? The gender identity clinics don't want them there. They all say that. We can't get back and nobody's taking care of us. So now what do you do with the 19-year-old who's been on estrogen for 12 years? Some of them have had surgeries that really didn't go that well. And how do you transition them back? How much hormones do you give them back? How do you do that? Nobody knows. Nobody knows, and nobody's trying to find out. So this is a real problem. Well, let me get to the sex reassignment surgery. Again, we're told it's safe and effective, and it is not. And it's difficult to find out how much of this surgery is going on. But this study from Columbia University, 13,000 surgeries in 2019. It's come down a little bit in 2020. And when you look at it, most of it is breast and chest. And then these are the younger patients. Older patients have genital surgery and then facial surgery to make them look more feminine. But what I thought was impressive is that almost 8% are on minors. That again can't possibly consent to having their breasts removed or having their genitals changed. In terms of payment, 30% are, and with some government agencies, 60% are private and about 6% are private. So how do we go from being a man to a female? Now, I didn't bring my usual lecture. If you want to see my usual lecture, come to our annual meeting, because I'll show all the gory pictures. I didn't want anybody to vomit today, so I didn't bring those pictures. But I'll describe what's going on. So to go from male to female, there's complementary hormone therapy, then breast augmentation. These are men who are getting breast implants. After they receive hormones, the chest tissue softens a bit. Then they have genital surgery and then supplemental, something to do with their forehead, their trachea, or whatever. Now, in order to do the genital surgery, the first thing is an orchiectomy, which is castration. You remove the testicles. And then you have to disassemble the penis. Now, the penis has 3 parts to it. And so you leave the skin and you leave part of the corpus spongiosum that has a neurovascular bundle in it. And then you amputate the rest of the penis. And you create a space that doesn't exist anatomically between the rectus and the bladder. And in that space, you invert the penile skin. Now, of course, that space is going to try to contract and close. And it's the big problem because it's a wound that's trying to contract. And then you have to create the urethra. So a man has a long urethra, women have a short urethra, so now you have to shorten that urethra, and then you can create the labia majora from the scrotum. Now, this study from the Department of Urology in Philadelphia by Dreyer looked at the complication rate, and she reviewed 125 articles, but only 13 met the criteria for review. That means, what does that mean? And, there's 125 articles in there, but only 13 actually talked about what the complication rate. They documented the paper well. And so that's still 1,684 patients. The overall complication rate was 32%. And when there's stenosis of the neomeatus of the urethra, what that means is you need a catheter to urinate, right, or a suprapubic tube. That's a serious life-altering event. Stenosis of the vagina is about 10%. So these are serious complications. And then when you look at this paper that comes from San Francisco, this is an incredible paper. Their complication rate was 26%. Now these, the author calls minor complications. So granulation tissue means that tissue isn't healed, and there's called what we used to call crowd flesh. It's just weepy tissue that doesn't have epithelium around it. Intravaginal scarring, prolonged pain, 22%. Incontinence, so now you're living with a diaper, 15%. And retention, you need a catheter, 9%. Vaginal drainage, 13%. Another 50%. So those complications, I would not call minor. Urinary incontinence, prolonged pain, I would call major complications. What they consider major complications were necrosis, which is that all that tissue just dies because it's outstripped blood supply. Hematoma, emergency operation, complete stenosis. So total complication rate of 70%. A reoperation rate of 50%, and 32% of the patients requested another surgery. So I can tell you, if I had a complication rate in my microsurgical cases of 70%, I wouldn't be standing in front of you. My license would have been gone years and years ago. Yet, this is published in the American Journal of Plastic and Reconstructive Surgery. This is a very reputable journal. I mean, there's no higher standard in the United States, and yet we're accepting this like this is, oh yeah, this is just how it is. All right, I have a few minutes left. A female to male, very difficult surgery. And so these women undergo mastectomy, their breasts are removed, the vagina is removed, and then here's the difficult part again. Women have a short urethra, now we have to make a long urethra to make this new penis. Metoidoplasty is making a penis out of the clitoris, which has undergone enlargement because they've been on testosterone. It doesn't work. Most of these patients undergo phalloplasty, so you take most of the forearm on the radial artery and vein, and then you transplant it to the groin, and that takes microsurgical skill. And so these are skillful surgeons. These aren't they're skillful, and in the Scandinavian countries have been doing it for a long time. And yet the complication rate is very, very high. All right, so what is, this is an article that comes from Amsterdam, and so the single institution, and it was urology and plastic surgery, which is actually the best it's ever going to be. When you can get a team of urologists and plastic surgeons from one institution working together all the time, you're not going to do any better than they do. And what are their results? You read the scripture, 63%. So these people need a catheter in order to urinate, or inside your bladder. Fistula, 50% and 27%. These people are living in diapers. Revisional surgery, 73%. But they patted themselves on the back because eventually patients, some of them, 44 patients, were able to void from the tip of the phallus. And they congratulated themselves for these wonderful results. Now, certainly we're doing all of this because it's proven psychological benefit, right? And if you look at this study from Germany and Sweden, 15 years after these patients had surgery, the quality of life was lower in domains of general health, role limitations, physical limitation, and personal limitation. This came from a questionnaire, and I think there's even better data that comes from Dine, from Sweden, and this is a longitudinal population study. And so the wonderful thing about the Swedes is everything is in a national database, so they know exactly what the diagnoses are, And the follow-up was 10 years. In other words, these patients had surgery, then 10 years later, they wanted to see how they were doing. And the completed suicide rate was 19 times their cohorts. Not 19%, 19 times. And the patients that were female to male, it was 40 times. Transitioners had higher heart disease and psychiatric hospitalization, as we know. And then male to female had a high rate of criminality. So, about the surgery. These patients present with psychiatric disorder. Few studies actually try to measure their psychological benefits. If there are early benefits within that first year, those go away. And longitudinal studies fail to show the benefit, although we know there are hormone complications and significant surgical complications. And when they're reviewed, all the gender-affirming surgeries are of low quality, and that's why the national science reviews in these countries have changed course. So I hope I've convinced you in some way that Professor Gilbert is right. This could and probably will go down as the greatest scandal in medical history. So gender dysphoria is a psychological diagnosis. It's about identity. Psychologists are famous, the popular one. Jordan Peterson has made this point. It's about identity. All psychological illness is about identity. Who am I? What am I supposed to do? What am I doing on this earth? And this is all that happens in adolescence, and it's about identity. We've made it into gender identity, but it's about identity. Transgender ideology, on the other hand, is a social political movement, disregards public science, doesn't allow debate, and believe me, it's dangerous. And I'm left with we're thinking about Dietrich Bonhoeffer, who's a hero of mine from World War II, Lutheran pastor, and he said it best: not to speak in the face of evil is an evil in itself, and God will not hold us accountable. All right, thank you very much.